Good evening, everyone, and welcome to JA and Emotional Health, Navigating the Middle School Years webinar. My name is Dan Auslander, and I am a JA dad. Also, two other kids in the family, and I know how tough it is to watch your child struggle emotionally, physically, and mentally growing up with arthritis. That's why I'm excited about tonight's webinar. Our guest expert will share tips on how to help our children better cope with those coming of age challenges, as well as help ourselves navigate the tricky middle school years. Some important information about how this is going to work tonight. We have muted all attendees for this event. You can direct any questions you have throughout the presentation in the Q&A box at the bottom of your screen. We will reserve time to answer those questions at the end of the presentation. Also, after tonight's session, you'll receive an email about your experience. These surveys help us track the success of the sessions and better plan for future events. So please take the time to fill them out. Okay, now let's get started by introducing our expert guest. Dr. Jessica Auslander is a mental health professional working in private practice in Charlotte, North Carolina. She works with clients and families affected by chronic health issues and addiction-related disorders. As a JA parent and JA patient herself, she has served as a subject matter expert on arthritis and mental health for the Arthritis Foundation's Live Yes online community. She has also served on several local Arthritis Foundation communities and has been a member of the JA Conference Planning Committee since 2016. Now, without further ado, let's welcome my amazing wife, Dr. Jessica Auslander. Thank you so much for joining us tonight.
They were out there in the chair. I didn't see them.
Thank you, Dan. And welcome everybody. I'm so excited to speak on this topic. As you know, my husband mentioned, not only am I a mental health professional, and we have 3 children. They are 16, 14, and 12. So we have 2 that are out of middle school and 1 still in the middle of it. But I also was this JA middle school kid and had many of these same challenges myself. So I really love, helping JA families kind of get through this mental health piece, because I know what this is like as a kid and as an adult. So I know we have, you may be seeing like a gray box on your screen. We're trying to minimize that. So I apologize. We're working on that right now. But let's start with just learning a little bit about the adolescent brain. What is going on in your kid's brain? We know that the rate of change and growth in the brain during adolescence is pretty much the same pace as when they're a toddler. So think about when they were little, every day there was a new vocabulary word, there was a new skill, there was a new, something that just amazed them in their world. This is pretty much the same kind of pacing, but obviously the vocabulary is much bigger. But this rapid growth affects their cognitive abilities, their emotional abilities, and their spatial functioning. So these are the 3 areas that grow. And if you think of growth spurts, it often is not even. So you may have a few months where your child is very black and white, very cognitive, doing well in school, absorbing all the information, wants to know all the things. Then you may have a month or 2 of some emotional, some mood swings where things that didn't bother them before suddenly do. That kind of thing. So we know they've got this emotional kind of growth spurt that can affect their ability to feel their emotions, name their emotions. And sometimes the feelings may not fit the situation, and that's okay. That's all normal. The spatial functioning, this is kind of interesting. Their spatial development, when we think of spatial reasoning and spatial coordination, people tend to think of like geometry, learning geometry, but it goes beyond that. So their spatial reasoning abilities affect things like their ability to read facial expressions, read body language. So we get a lot of misunderstandings and miscommunication in adolescence because they simply can't interpret nonverbal cues appropriately, and that's completely normal. And then, of course, the good old coordination issues with JA can make it a little bit worse. Things like tripping, running into doors, not realizing how long their reach is. Their brain has to learn their body as it grows, just as it did when they were smaller. So we see rapid growth in those 3 key areas, and it's not growing at the same pace. brain development actually continues through the age about 25, 26. So we think, we've got these mini adults, right? We think they should know or should be able to handle certain things or should be able to learn certain things. But really that brain isn't done cooking until they're probably out of college, their mid-20s. So I know that sounds a little scary, but it's just normalizing a lot of this for them, that your brain is going to continue to grow and develop throughout the lifespan, but it's really not going to have all the tools it needs until, 10, 12, 15 years from now. So it's important to realize that these highs and lows are completely normal, right? We don't want kids to think something's wrong with them. So this is a great time for parents to demonstrate, teach, normalize not only the feelings and experiences they're having, but also these coping strategies and how to use them. So as they're going through all these changes, it's a great time to kind of catch these teachable moments and help them learn how to cope with these things while they're still, in the family, in the school, because those skills, will carry on as they get older. So it's a good chance to learn it now. As a parent, it may not feel like anything is sticking, but that's okay. This stuff, you're planting seeds, and this stuff will get better as they get older. Next slide. Okay, so let's look at what's kind of a normal struggle versus the JA related struggle, because when your child is diagnosed with JA or any other diagnoses, and I recognize some out there may have kids with we call co-occurring or multiple diagnoses, that tends to become our focus, right? We're trying to learn everything about this thing, this label. So we're seeing everything through that lens. And it's important to realize that some of the struggles your kids are facing, they likely would have faced that without the JA diagnosis. So here's a list of some normal stuff that JA can make a little bit worse. So body image, when we talk about body image, it's inside and out. So a lot of kids at this age, when we think of body image, we think of them staring at themselves in a mirror, right? Being critical of what they see. But kids with JA and chronic health and chronic pain are also becoming more aware of themselves internally. They're getting those chronic pain signals. They're trying to figure out, what pain can I push through and what pain do I have to listen to, right? I was this child. I was so stubborn. I completely ignored all my pain and all my signals. I was such a brat. I was determined not to let this affect me, which can be good. But at the same time, I grew up kind of hating my body on the inside because it was constantly in pain and constantly kind of failing me. My joints would give. I kind of looked klutzy. I'd trip a lot, kind of embarrassing me. So I was okay with how I looked on the outside, but my body image internally was a different story. So this is common with kids. We have to help them process not just how they feel about themselves and the feedback they get on their image, right, their visual, but also how they're relating to their body in terms of their experience of their body and of their pain. With self-esteem, some can really over-identify with the diagnosis. So on one hand, we have this label that a lot of people have embraced, the JA warriors, right? If you come to conference, you'll hear this used a lot, our warrior kids, they're fighters, they're fighting their disease. Some will over-identify that and only see themselves as a JA kid, right? Versus, I've had a child say to me, well, I'm just an arthritic kid. I said, well, no, you're Sarah, and Sarah has arthritis, right? So emphasizing kind of that person first language, you're you, and this is just a part of you. We want to be careful with that over-identification because we don't want it to define them, not just because of the self-esteem development, right? But also because this disease is a very flexible one. They're going to have natural ups and downs. I've been living with arthritis for 34 years now. Yeah, 34 years. And my disease has been up and down. And, when I think back on how I was as a middle schooler, I wish I could go tell myself, no, you're going to have stretches of time where it's better, stretches of time where it's worse. You got to roll with it a little bit. So we want to be careful with that, over identification, because it's going to change just like their interests will change, right? Just like, you're not going to be, the same height, body shape. You're not going to like the same people, same clothes, right? I try to normalize that this is going to be flexible like other things that are associated with you. Fitting in, right? This is a big thing in middle school. Part of that is that brain, that parietal lobe, it's on the sides of their brain. It's in charge of that spatial reasoning, and it's trying to fit in because we are social creatures. We are designed to fit in with our pack. So in middle school, that part of the brain that kind of helps with that is having this growth spurt. It gets very focused on fitting in. It's a normal developmental stage. It's a kind of a survival instinct. This is where we start to judge ourselves in comparison to others. That's okay. But when we get bullying and we get, kids being bullied as, oh, that kid with JA, or what's wrong with you, those kinds of things, that's where the normal struggles can get a little bit worse. As our oldest would tell you, well, if it wasn't the wheelchair, they'd find something else. I'm like, probably right. Because at this age, when they're insecure about themselves, they're going to attack another child. That's how bullying works. So they can feel like the JA is the reason for the bullying and the focus, and just helping them understand it's that other child's behavior, it's not you. Social isolation, especially with COVID protocols. Now, I just saw a great webinar earlier today on suicidality in adolescents. And what the data are showing us is that suicidal attempts and death by suicide actually dropped during the home isolation period and the year of online learning. It actually dropped significantly and went back up when we got back into hybrid learning or face-to-face learning. So we know the social isolation and the COVID protocols did have an impact, but not every child experienced that as negative. So 2 of our kids kind of loved it, and only 1 of our kids didn't like it. Our older 2 thought it was great. They loved being at home and loved not dealing with their peers. So that social isolation, though, for JA kids, if you are looking to attend conference this year, it's fantastic. Or if you have local JA events you attend, we had to make those virtual for everybody's safety. Those kids were affected by that because with that social isolation, that also includes that JA social group, or if they have other children that they know with other diagnoses, they needed that connection. So, I'm not going to assume that the COVID protocols affected everyone in the same way, right? Some kids it was a benefit, some kids it wasn't. But just knowing that, JA could have made that transition for your family a little bit different. And puberty, right? We hear about hormones in puberty. Hormones are simply chemical messengers. They just tell other parts of the body to do things. That's the definition of a hormone. So it creates a lot of changes in the brain and body, and it's needed for development, but you don't want to minimize the impact physically or emotionally. So on one hand, we don't want to say, oh my gosh, your hormones are kicking off, right? And kind of stigmatize it. But we also don't want to discredit that there's just a lot of change going on, and they're trying to adapt to that the best they can, right? And then also important to consider medication usage. Now, I'm not going to give medical advice. I'm not your rheumatologist, but there is research emerging that some of the JA medications can have cognitive and emotional side effects. The biggest one we're kind of keeping an eye on in psychology is methotrexate. We're not quite sure if it's because of the immunosuppression or the use of artificial dyes. We know artificial dyes are a neuroirritant. There's research in epilepsy, autism, encephalitis, other medical areas, that artificial dyes, so your reds 40s, blue 1, yellow 5, those are actually kind of irritating to the brain and can cause headache, hyperactivity, pain, seizures, all of those things. And a lot of our kids already kind of don't like the methotrexate yellow. They have that phenomenon. So they could be having an emotional reaction, pairing it with how that medication makes them feel. But we also know in the cancer literature, the pediatric oncology literature, they're starting to see an impact with methotrexate in higher doses. So our personal experience, the second our son could transition off of methotrexate to sulfasalazine, it made a world of difference for his mental health. He noticed it and was old enough to verbalize like, whoa, that just felt like, the fog just lifted. That was really strange. But he was in treatment for anxiety. And it was, for us, it was getting him off the methotrexate. It was a huge factor. So just be aware, we don't have a lot of proof about the biologics. The biologics seem to be pretty safe in terms of a brain and mental health aspect, but it's the immunosuppressants, particularly that methotrexate, that seems to be where we see the trend for kind of medication-induced anxieties and depressions. Next slide. Okay, so given all of that, I know we're just scratching the surface. What are some coping tips, right? How can you help your child? Validate, validate, validate. Their experience is real. even if it doesn't seem as real or intense or as logical to you or somebody else, right? If they have been a rock star with their injections for years, and all of a sudden it's a traumatic event, that's real to them. So you want to validate and ask these open-ended questions. Tell me what this is like for you. Tell me what your experience is. If you had a magic wand, what could we do to, make this better, right? You want to back your child up and believe them no matter what, because they're trying to figure this out. Many times kids try to minimize or rationalize, right? Because they don't want this to be happening. So they may have been minimizing their experience, and now the change in what they're communicating, that might be their reality. So whatever they're sharing, validate it, get alongside them, walk this path with them, get them to open up and keep talking about it. Even if it doesn't seem logical, because they may not be communicating effectively, and that's okay. We want to encourage the communication. Normalize it. So you want to take the fear out of the experience, but don't stigmatize it. So we don't want to go to, oh, this is just, you're just being a moody teen, or this is typical teenage angst, honey, it'll be okay. We want to normalize it in a way that takes that language out. We want to say, you know what? This is totally your brain being healthy and developing, and not everything's going to feel good. I like to use the parallel of growing pains. Well, you remember when you were a kid, you kind of had growing pains or some aches, you'd be tired. Yeah. Well, your brain does that too, but this is what it looks like instead of aches and pains. Would you expect, someone like you to not feel this way? It's totally normal to be nervous about a shot, right? So you want to normalize it without using some of these kind of weighted phrases that they've probably heard before from frustrated adults, right? We've all said it. But you can say, hey, this is normal for, a family like us. Of course, I would expect anyone, to have this reaction, or you're a normal kid going through an abnormal situation, right? We want to normalize it because they're already a little sensitive to this age to thinking that they're weird and different and everyone's always looking at them. We call it the spotlight effect. But every kid feels that way. So I said, well, you're not looking at each other because everyone thinks you're looking at themselves, right? So we have to watch that, how much that they're internalizing this. Just, hey, this is normal. I bet if you talk to 5 JA kids, at least 4 of them are going to say the same thing you will, right? Anything you can do so they don't think that they're different or it's weird. And focus on the present. What can we do now, right? So we can't, fix the fact or change the fact you've got this doctor's appointment you're worried about, or you have a surgery coming up, right? We can't change what happened in your appointment last week, or, you not being able to participate in a sport or something at school and you feeling embarrassed. But what can we do right now to make this better? What kind of comfort things can we engage in? What kind of things can we talk about? Even if it's a distraction, what can we do right now? Well, we can watch a movie. Cool, let's watch a movie. You want to try to keep it present focused, because an adolescent brain is really is going to bounce back and forth between everything in the past being absolute, like everything is going to happen to me because that happened to me before, right? Or going into the future and saying, well, this is never going to get better. I'm always going to be this way, or they're not going to do this, right? They like to think forward or backward. We want to try to keep them in the present. That's this concept of mindfulness. You can look that one up. There's a lot about mindfulness. But anything you can do to draw them to the present, because this is where we have control. Can't control what already happened. Can't tell the future. I don't have my crystal ball, but we can control right now. So when we talk about mental health, especially with kids with chronic illness, comes down to control and autonomy, which is that independence, that feeling like I can have control over my body. So, anything you can do to give them control over the situation. They may not be able to say, no, I don't want that injection, right? They may not get a say in their treatment plan per se, because we have to kind of get aggressive with treating the disease, but maybe they can have control over if that shot is Friday night or Saturday, the kind of candy. So if you don't know this trick yet, if you have a child that takes injections, pop a sour candy in their mouth when you stick them with the needle, the brain's going to get confused and focus on the sour sensation. They probably won't feel that needle stick. We did that for years, worked really well with our son. But we give him control. When do you want to do your shot? Do you want to do your shot Friday or Saturday? Do you want a blue sour, gummy, or a red sour gummy? Do you want ice cream or pizza for dinner? Things like that, that gives them some sense of control and some sense of say over their body, because they can't control what's happening to their body. And that's really scary when your brain isn't quite done developing and getting that perspective. but anything we can do to give them a sense of control in the moment and anything in their treatment that they can decide, it's going to help with that anxiety. Next slide. So this is one of the questions I frequently get asked. How do I know when to worry, right? Everyone has a range of normal, right? So all this information I'm giving you is kind of a really broad overview, but what's normal for one child may not be normal for the next. So as a mental health professional, we look at defining kind of a significance of symptoms when it's a barrier to functioning or there's a noticeable change that's not very constructive. So I love to use the analogy of swelling, right? Our kids understand joint swelling. If your ankle's a little swollen, but you can still walk on it, that's different when if your ankle is so swollen, you can't move it, right? So is there a little bit of swelling? Are there a few symptoms? Or is that swelling interfering with the function? So if there's a noticeable change in behavior that's not constructive, that's when we worry. So if your child, starts sleeping instead of 5 hours a night, they're sleeping 8 or 9 hours a night. At this age, that's actually a constructive sudden change. We'll keep an eye on that, but we actually would expect to see the child more well rested and things like that. If it's a sudden change of, I was sleeping 8 or 9 hours and now I'm only sleeping 3 or 4, well, that's not a very constructive change. So we look at a significant change that really gets your attention, that is not helpful, or whatever that symptom is, being a barrier to their functioning. And what can be a barrier to one child may not be a barrier to another. So when we're looking at assessment and diagnosis, we really individualize it to that child, and it's helpful to get information from the families as to what baseline is and what's normal for their kid. Next slide. So what do you look out for specifically with the middle school age, right? Social withdrawal. Now this, kind of put an asterisk on it, but depending on your child. Our older two kids have very small social circles. For them to kind of withdraw, it's like, how do we notice, right? They like to be very independent and they're introverted. Our youngest is very, very social. If he were to suddenly withdraw from his peer group, that would get our attention, right? So we're looking at, again, that drastic change in functioning. Changes in eating, sleeping, and activity levels that aren't pain or disease related. Eating, sleeping, and activity are powered by a chemical in the brain called serotonin, and that also regulates mood. So when we look at things like depression, we typically see changes in eating and sleeping go with it, and changes in energy level, because it's the same neurotransmitter, the same chemical involved. So that's why you tend to see that clustered together. But we have to be careful that it's not pain or disease related, because we don't want to over pathologize. We don't want to over, add these diagnoses to these kids if it's just kind of normal for how they're experiencing their symptoms that day. Sudden decline in academics, again, looking at sudden. So if they had, their routine, their habits, and all of a sudden they stop, that's a sign that something else is going on. And loss of interest in multiple activities. So the brain goes through a process at this age called preening. And if you think of the brain as a giant tree with all these branches and limbs and leaves everywhere, right? That is their early and middle childhood brain, right? All these different directions, a lot of imagination. They want to do everything and be everything when they grow up, right? In adolescence, it starts to, they say preen. So all these branches start to kind of fall off or come inward. So instead of a tree like this, it kind of starts to round out, and they naturally lose interest in some of the activities. So for some parents, they love the decline. And if you had a kid that wanted to do every single sport, right? Now they maybe have one or two. We're kind of relieved, less driving around. But if it's a loss of interest in multiple things in a short period of time, that's when we get concerned. So I'll have parents say, I'm really worried. They were in all these clubs and now they only do like 2 or 3. Like, well, that's natural preening of interests. We see that the brain just starts to focus its energies a little bit more, and they go deeper into things that interest them instead of, touching the surface of, dozens of things at once. So we look at loss of interest in multiple activities, not just, a couple. Next. So clinically, right? So if we think there's something going on, this is just to give you a little bit of background information from the mental health standpoint. So if you were to talk with a professional, this is kind of behind the curtains. So remember, a lot, there's a huge range of normal that's subclinical, meaning it's not severe enough to be diagnosable. So there's a whole range, you can have a depressed mood for a couple days. That's normal for everybody's brain. That's okay. We go by a book called the DSM-5-TR. This is the current psychiatric diagnostic manual. It was updated in 2013 and then again just a couple months ago. So to give you an idea, this is how thick this book is, and it's a really tiny font. But this is the diagnostic manual that's used by doctors, psychiatrists, psychologists, counselors, social workers, marriage and family therapy, anyone in mental health. We work out of the same book. So there's a variety of professionals you can go to, you'll get the same information. Mood disorders are diagnosed differently for kids and adolescents than adults. And if you're an adult that maybe has experienced this process or are living with a mental health disorder yourself, or maybe had one as a kid, what I really want you to take away from it is that the science has been evolving so rapidly in mental health, even with the revision of, this book, that how you saw it or you experienced it when you were a child or adolescent, it's very different now. Even 5-10 years ago, I mean, so much has changed. We're getting so much more information that they're putting into these diagnostic manuals. So we do look at it a little bit differently. As adults, we really want to watch the use of our language because it can be very stigmatizing. And a lot of the clinical terminology has kind of made it into layman's terms. So if you've ever said, oh my gosh, I'm so addicted to M&Ms, right? Well, if we look at the criteria for addiction, you probably aren't addicted to M&Ms, but when we throw that word around, it starts to lose its meaning or starts to get some stigma attached for the actual disorder. So when, kids will say, I'm so depressed, I want to replace that word with, tell me more about how depression feels to you. Do you feel sad? Do you feel irritable? Do you feel angry? We want to really use specific emotion words and not use this kind of clinical or diagnostic words, because kids will start to identify with that label so quickly. I have really bad anxiety. And I'll talk to them. I'm like, well, actually, that's normal things to worry about, and it's not really affecting you. So you may feel anxious, you may have worries, but I'm not going to say you have an anxiety disorder, right? So we want to watch the words that we're using. We want to model using the specific feelings words to see if that resonates a little bit more. Next slide. So just to give you a quick example of kind of the difference with childhood stuff and adult stuff. So if you are going through the process with your child and you end up with a diagnosis and you're like, I have never heard this terminology before. Again, we have some things that are developmental and childhood specific. So for example, this DMDD, disruptive mood dysregulation disorder, for a depression diagnosis, they can have an irritable mood instead of a depressed mood, and that counts as clinical depression for children. So it can present as irritability. Weight gain is categorized differently. So for an adult, we're looking at sudden weight gain. For a child or adolescent, they're still developing, right? So we're still looking at them on a curve. So the weight gain is looked at a little bit differently. Dysthymia, also known as persistent depressive disorder diagnosis. And in adult, we look for symptoms for 2 years before saying it's dysthymia. With kids, it's 1 year. Separation anxiety, that window of symptomology is shorter. 4 weeks versus 6 months, right? So big difference there. And generalized anxiety disorder, they only have to meet 1 of the 6 criteria instead of 3 of the 6 criteria. Next. So a lot of the hitting these diagnostic categories, we're talking fewer symptoms because their brains are so varied at that age. So what are the most commonly diagnosed disorders in kids? So this is CDC data from 2016 to 2019. So as we have to classify now pre-pandemic, ages 3 to 17, ADHD is the most commonly diagnosed. 9.8% of children have an ADHD diagnosis. And again, we have a better understanding of that disorder than we ever have before. Anxiety is about 9.4%, and about 60% of kids with an anxiety disorder get care. Behavioral problems, it's a close third at almost 9%. About half of those kids get care. Depression is only about 4.4%, but it's good to know that 8 out of 10 of those kids are getting care. And about 3/4 of those kids have at least one other diagnosis or co-occurring diagnosis, right? So as for adolescents specifically, that kind of older age group, we know depression, suicidality, and addiction-related disorders are actually higher. So when you take all this data, so the ADHD, anxiety, behavior, depression, that's 3 to 17. But if we pull that out from 13 to 17, it's actually the depression, the suicidality, and addiction-related disorders are the higher ones. Suicidality has been steadily climbing since 2007. It actually had its biggest jump between 2015 and 2017. It's still at its peak. It has not been this high before in terms of rates of suicidal ideation among adolescents, but it did not spike during the pandemic as many people assumed. It has been kind of steadily climbing. Next slide. So we know if you have an older, maybe 8th grader, maybe young high schooler, we're looking more for those disorders. We know that these disorders are higher among LGBTQ populations. COVID, during COVID, we estimate that the rates of anxiety and depression have doubled amongst the general population. So that's including kids. So that's kind of a rough estimate. Part of that is just the data gathering, right? A lot of people affected by COVID either developed a brain-based mental health disorder as a side effect of long-haul COVID, or they just had more access to care because telehealth expanded. So part of this could be just it's getting reported more frequently. And the prevalence of these diagnoses and these disorders increases with the age group. So we have more kids at an older age having them at a younger age, but that's also normal as the brain develops. It's normal to have onset in that late teenage years, especially if there's any kind of family history, because the brain's a body of the organ, just, organ of the body, just like other organs. So you can have a genetic predisposition to diabetes, for example, just the same way you can have a genetic predisposition to anxiety, depression, or addiction. So when this onset is happening later, it's not necessarily anything to do with us as parents or what's going on. A lot of it's just normal brain development. You're more likely, if you have a family history or genetic based brain disorder, it's going to express itself before that age of 25. So part of this is just, it's normal for it to happen as they get older and get a little closer to their 20s. Next slide. So let's look specifically what the research says about mood disorders and JA. So kids with JA are going to experience symptoms of depression and anxiety at similar rates with kids with other chronic illnesses. So it's not just JA, other chronic illnesses, they're kind of on par with those kids too in terms of the rates of anxiety and depression. Still higher than children without any diagnosis, right? And we know there are studies that have shown that there's a lower quality of life measure if uveitis is involved, right? It's kind of a 1-2 punch. And a couple studies have demonstrated that the mental health symptoms actually have more of a negative impact on quality of life than the arthritis symptoms. So yeah, when we're thinking about, oh my gosh, my kid can't participate in that, or this has to be modified, or they have to take these medications, the kids actually learn to cope and kind of roll with that better than if there's a mental health disorder. So that's why it's important that we're kind of looking at the whole child. And then research shows that family members and caregivers can have higher rates of anxiety and depression too, which also impacts the child. We know that parents of children with chronic health issues or special needs have a higher rate of divorce, have a higher rate of other forms of psychopathology. So because the caregiving burden, it takes its toll on us. So of course, if we're feeling stressed and we're having, issues, it's going to impact the child as well. Next slide. So the brain and the body have a connection, right? So we've got some data on the impact of mental health, and disease symptoms, but it's pretty conflicting. Some studies say, yes, there's a connection from brain to body. Some say, no, it's body to brain. Some say there's no connection. So we've got conflicting data like that. What does that tell us as scientists? That tells us we got to look at the individual. We don't have that subject pool, clear enough to really rule out all these other factors. So we're looking at, okay, is my depression or anxiety affecting my body, or is the body causing the mental health symptoms? Really depends on which study you read. So that, we're really going to say we're going to look at that at individual factors. There is this idea of somatization when stress affects the body. Now, there are the physical impacts. If we're upset or we're stressed, the body naturally releases adrenaline, puts us in the fight or flight. Part of fight or flight is activating the immune system to protect us in case we get wounded in battle, right? But for our kids, they already have an autoimmune disorder. Their immune systems are already on overdrive. So what's the result? Increased headache, muscle aches and pains. Children particularly will have stomach aches, mom, my tummy hurts kind of thing. So kids will have more of the stomach involvement. And yes, it can cause an arthritis flare. So again, it's because if that fight or flight response is activating that immune system, it can override even the best biologic, and your child can flare even briefly. So we know that the brain and the body are connected. There is some research looking at inflammation in the brain. There is a theory right now that's being tested about depression, certain forms of depression actually being immune responses. So looking at a flare can cause cognitive and emotional symptoms. So, we talk about brain fog a lot in our house. I have spondyloarthritis. When I'm flaring, I just get foggy, and I tell everyone point blank, I'm a little foggy today, just bear with me. Because I know if I'm not feeling good, I can tell when I'm that cognitive piece, there's so much immune particle running through my brain, I can't concentrate very well. And we know it can cause emotional symptoms. If you think about it, your child may be planning to do something and then they flare or they have pain and now they can't, and they're going to have a reaction to that loss. That's okay. So the flares not only can cause the emotional symptoms because they have to cope, but also can cause those symptoms because the impact of the immune system running through the brain. Next slide. So specifically mental health needs of JA kids. So I read a bunch of studies. I'm a psychologist. I love to read research. This is kind of what I gathered. What are their primary needs? Illness-related anxiety. So anxiety specifically about arthritis. So it's talking to them, connecting them with peers. If you know adults in your life that have arthritis, or there's a phrase, JA persisting to adulthood. Some of us have had it as kids and are now adults living with it. Connect them with these people so they can learn about their experiences to help that anxiety. Adjustment, coping, distress, that's kind of normal teenage stuff, right? But just adjusting to the diagnosis. Any transition is going to have a little bit more stress for JA kids, because something as simple as, oh, I've got a substitute that day. For another kid, they might be thinking, all right, we got a sub. A JA kid may be thinking, are they going to have my 504? Are they going to know what to do? What if I need help? What if we have to evacuate, right? So transitions can be a little more challenging. Parent and caregiver mental health is a need. Our kids need us to get healthy. And they need peer support. This is why the foundation does so many wonderful things with conference and local events. So what are the barriers to meeting these needs? Limited resources. We know, especially with the pandemic, mental health resources, we are all booked. We are all full, and we're doing the best we can. And there's legislation to try to expand telehealth, allow us to cross state lines, things like that. It's coming. But we know there's a lack of resources and lack of protocols specific to JA. So one study looked at how many hospitals and rheumatology departments and clinics had embedded mental health. And it was a very, very small percentage, because we don't have mental health protocols that overlap with rheumatological protocols. So docs don't check that box to integrate it into the care plan, right? We were lucky when our son was diagnosed at Nationwide Children's Hospital in Columbus. They have a health psychologist on staff that actually started to work with our son about his fears at the age of 5 about getting a cortisol injection and swallowing pills. He'd never had to swallow a pill before, but that's really rare. So we don't have mental health protocols that are specific to JA. So it's not in that best practices from a rheumatology perspective yet. And then of course, the financial and the time burden. Next slide. We know therapy can be expensive, may have varying insurance coverage, and just the time it takes. Now, I don't want to forget about the positive. Our kids are amazing, resilient little beings, right? Don't leave out the positives. So the CDC data on the positive mental health indicators, things like if they're showing affection, if they're curious, that resilience, they're kind of going with the flow and not letting things, completely disrupt life. If they have positivity, if they're being positive, oh, that's okay. Or, the growth mindset kind of thinking. And if they can exhibit self-control, which, okay, teens, we know what that means, right? Self-control really varies. But if they're demonstrating those things, that's actually a positive indicator that they're doing okay. Next slide. So prevention, how do we prevent issues with our children? It starts with us. I know it's hard. Trust me, we have 3 teenagers. It's hard, but it has to start with our own mental and physical health. Can't pour from an empty cup, right? All these sayings, but we have to check ourselves first, not only so we can be better people and healthier and take care of our kids, but we are also setting the example. We have to show our children, this is how you deal with mental health throughout the lifespan. This is okay. High social support is a great preventive factor. Doesn't matter where it comes from. a lot of communication. Get your kids talking about anything and everything, because if they'll talk to you about the little things, they'll talk to you about the big things. And then again, that autonomy, engage them in that decision-making as much as they can. They already want control over their lives. They already think they know it all, right? We're idiots, happens at this age, but put them in the driver's seat as much as you can. And then look up the term self-regulation and distress tolerance skills. Stress tolerance specifically is the kind of category of skills of how do you handle when something is uncomfortable or something is happening that you don't want to happen. We call those skills distress tolerance. Next slide. There's a lot of information. We're just scratching the surface here. So what can you do, more as a family? Emphasize, the positive things that are going on. Oh, next slide. Slide disappeared. Emphasize the good things that are going on in your family or your house, right? What's going on in their lives. Find time for fun. This is that quality of life piece. Yeah, your kid may have to shift how they do things or what their interests are, but you want to help them, find time for this and make space for this. We need this more as adults too. But that's going to help that quality of life. Self-advocacy, helping them find their voice, helping them identify their own wants and needs and make the ask. So sometimes you can feel like a broken record, right? What would that look like? So what are you really saying? What do you really want? What would make this better? But you want them, you just want to guide them. You want to ask the open-ended questions so that they find it themselves. And it's okay if it changes. Dear man, if you're not already taking notes, if you get nothing else, write that one down. Dear man is an acronym. It's a DBT. It stands for Dialectical Behavioral Therapy. But you can Google Dear Man DBT skill, and you'll see the acronym. And it's a great way, a great template for how you express a need, assert something that, be assertive for something that you want in a way that's balancing thoughts and feelings. It's great for adults, not just for kids. But focus on your kid as a whole, not just the JA, right? So many parts of them are growing and developing. And I know as parents of special needs kids, it's really easy to get focused on the diagnosis and the care plan and the appointments and the resources and the insurance battles, right? How much time do we spend on insurance stuff that we don't want to lose, the focus on the child as a whole. Resist that urge to be overprotective. With JA, there's a lot of resilience. When I was growing up with JA, it was a lot of immobilize and, mobilize the joint, stay off of it, don't move, don't do anything. Now it's kind of the move it or lose it, right? We want the kids to be active. So it was a hard shift for me to make because I was raised with sitting on the sidelines, in braces and crutches and being careful and being treated like I was this fragile thing. To now I'm encouraging my kid. Now I can't get him to move enough and be on his own. But we want to resist the urge to be overprotective at this age because we need them to make mistakes. We need them to learn now. We need them to try to advocate for themselves to that substitute teacher and maybe get embarrassed and not know how to do it yet. We need them to go to their 504 meetings and speak up, right? Because this is when they learn those skills. If they don't get them now, they're not going to magically turn on as an adult. If you are concerned about the overprotectiveness, there's this great book called How to Raise an Adult by Julie Lithcott-Hames. It's on Amazon. It's pretty affordable, but it's a great book that talks about kind of this helicopter parenting and how to break that cycle. Because when you have a kid with a diagnosis and special needs, yes, all those fears are there, but we want them to be independent and be self-advocates because we're not always going to be there, right? To take them to that appointment and to, you're not going to be following them to work one day asking for ADA accommodations at their job. So we want to take advantage of this time, this part of development. Don't wait till high school. Do it now. Start to have them, try to find their voice and start working on these advocacy skills. Next slide. So we talk about, I get asked about intervention. When do we pull the trigger on this? When do we actually get professional help? There's no wrong time to engage in professional help if the child is willing. So we don't want to force counseling and therapy, but we also don't need to wait until there's a crisis for someone to benefit from counseling. Specifically the counseling field, that's where my clinical licensure is, so I speak more to that. But it's more strengths-based. It's less of the medical model of what's wrong with you. It's more, hey, what's going well and how we can, how can we build on that? There's no wrong time to engage in that. And it's great to start it, sometime during adolescence, to normalize going to therapy like you'd seek any other, physical therapy or, medical appointment. So we want to normalize it. It doesn't have to be weekly. I have individuals I see twice a week. I have individuals I see 3 times a year. So it's not this structured, standardized thing. It's really, what's going to work for your family. Start with your pediatrician. They usually have referral lists of who's really good for different issues. And they can also provide that consultation if medication use comes up. So if you think, possibly an antidepressant or anti-anxiety medication could help your child, or if there's a drug interaction, your pediatrician is a really good resource because they can kind of coordinate that care among the specialists and talk about, ADHD meds versus serotonin reuptake inhibitors. So start with your ped. It's a great place to get referrals. Counseling. There's so many options with counseling. If you have an employer that provides an EAP or employee assistance program, check it out, look into it. It typically provides a certain number of sessions for free. They'll match you with a therapist and it's completely free to you. It's a great way to try it out because if your kid doesn't like the therapist, you didn't pay for it, little tip. But it also is a way to kind of normalize because if you start the process and maybe the kid's not into it, doesn't like therapy, again, you're not out of pocket. And it's a great way to get started and kind of get the kids on board. Well, hey, just try it. We only have 3 sessions or 5 sessions anyway, so it's not like it's forever, right, to get the kid on board. Check with your insurance. And then there's always private pay, and many providers will do sliding scale. There's a network called Open Path. It's therapists that provide free or reduced fee therapy. You can go on a website called psychologytoday.com and find therapists in your area that way. There's a lot of resources out there. And when we look at therapy, there's individual therapy, group therapy, and family therapy. So there are a lot of options. A pediatric psychiatrist would be a professional that also can prescribe medication. So there is child and adolescent psychiatry as a subfield. A pediatric health psychologist might be within your hospital system, look it up. It's not child life, it's actually a division of psychology, and they focus on kids with chronic illness. And then pain management can address that mind-body connection. Pain management isn't simply throwing, opioids at our kids. It is helping them learn to live with that pain within their body, especially pediatric pain management. They do a lot of the body-mind connection and less the medication management because a lot of those meds aren't cleared for kids. So having a pain management specialist on your team can be really helpful for the mental health stuff too. Next. Okay, questions. I know it looks like there aren't a lot in the chat. I know we had some questions ahead of time.
We do.
Let's see.
So
What do
we're
you
going
got?
to take time now to answer questions. And as a reminder, the QA box is open. All the participants can add questions to that, and we will see them. But to start here, we are going to go through some questions that we received in advance. First question is, my child's disease is uncontrolled. I suspect it's partly from their habits. She's addicted to sugar, refuses
I think we're losing Dan's audio.
to exercise. Can y'all hear me now? Can y'all hear me now?
Okay, now we got you.
Oh, great. So if we got me, the question is, my child's disease is not well controlled. I suspect it's partly from her habits. She's addicted to sugar, refuses to exercise, and is staying up late. I think these behaviors are also contributing to her poor mood. When I try to talk to her about it, she shuts down. How can I help motivate her to take better care of herself without it coming off as nagging or being controlling?
Yeah, I think that's a challenge for a lot of parents, right? Especially when we get into the sugar stuff. When we've got the sugar, the refusing to exercise, the staying up late, right? They're really kind of leaning into those impulsive internal cues from their body. And it's helping them make a connection as to how that's not helping them meet their goals. So it's helping the kids kind of clarify, hey, what do you want to be doing? You know, what are they doing when they're staying up late? What are they getting from that? What's that benefit? Are they staying up late talking to friends? Okay, if it's a social connection, can we move that earlier in the day and maybe in person, try to motivate them? You know, when we've got the kids in sugar, we know, and I know there's a session coming up too about the the gut biome, the microbiome in the gut. But sugar really feeds that and can, you know, cause a lot of issues for flaring with arthritis. So helping, you know, just give the kid the information. It may take several times, several conversations, but you give them the information and you let them make their choice. And it can be hard as a parent to watch them make the wrong choice, the bad choice. But you can say, you know, I notice when you eat a lot of stuff and stay up late, you really seem to be achy and tired the next day. Is that okay with you? You know, just kind of presenting what you see and see their response to that. There was a question about removing the dye from methotrexate. Yes, it's an option. We have a child that has to take methotrexate twice a week for an autoimmune disorder that attacks her brain, autoimmune encephalitis. And we actually were able to talk to our pharmacist because different drug manufacturers use different inactive ingredients. So, you know, what methotrexate is, you know, from Teva is going to be different than Pfizer because once those drugs are no longer patented, all the companies making the generics have to basically prove why there should be marketed, why it should be allowed. It has to be slightly different. So if you look at your labels, right? I know it's going to run to their medicine cabinets after this, but look at your labels, look at the drug manufacturer and if it's been consistent month to month and look up, you know, if you get the information that we never read, right? Because we've been on this forever. But if you look at that information or just Google the drug name plus the manufacturer, or go to the manufacturer's website, read through that patient information and look for inactive ingredients. Typically, when we have side effects to medication, especially for the brain, the side effect isn't to the medication itself, it's to the additives, it's to the packaging around it, the different chemicals that are needed to get that medication into our bodies and where it needs to go. That's usually what we have side effects to. So yes, there is a dye-free methotrexate option.
And speaking from a non-clinical standpoint, the difference is those little pills are beige versus being bright yellow.
Good point. Yeah, they will look different.
Next question that we had in advance. What are some tips to help my family cope with the anxiety of having a sibling who has a chronic disease?
Yeah, you know, it goes back to, you know, quality of life. Yes, there's a lot of anxiety when someone in the house has a chronic illness. There's a lot of variability in life. You may not be able to plan. It may feel very chaotic, but it comes back to taking it kind of one day at a time in the moment. I'm a big fan of humor, especially dark humor. We have a lot of dark humor in our house, laughing at things that might be inappropriate. It's a great coping mechanism. There's actually research to support it. So that's my defense. There's research to my snarky sense of humor. But as a family, finding things that improve that quality of life to try to pull the focus off of the chronic illness, right? If the sibling with a chronic illness is kind of going through a rough patch, making sure you've got some time, you know, with the other siblings, right? Make sure you got some time with the other kids to have time one-on-one, you know, for them. So we have a child with a food allergy. And one of the things we would do right when that food allergy hit and we kind of were in panic mode of taking everything out of the house, I used to take the other two kids out so they could just binge on the food that we couldn't have in the house anymore. And they loved that. So it's just finding ways as a family to do things that are fun, engaging, and looking at that quality of life piece.
Cool. Thank you much. The next question, how can I coach my child to talk comfortably with other kids when it comes to questions about the condition? For example, need for meds, sitting out in gym class, things like that.
Yeah, it's hard to help kids talk to their peers at this age, right? Because they're already convinced of what they're going to say and do, right? How many times we heard it from our kids? I can't say that. They're going to say this. So it's going back to that dear man. Now, of course, you're not going to have it as structured. They're not going to be reading off of a script, but just kind of that balance of, hey, you know, this is what I need and this is why. And if this isn't okay, here's the compromise, like kind of preparing for that. But helping them, you know, practice saying the words out loud. I mean, Dan, how many times have we had conversations with our kids and, you know, we'd say, well, say it to me like you're going to say it to them. Right?
Yeah, absolutely. And, you know, even had the conversations, okay, well, why do we even think this is going to come up in school? Or if it does, what can we say about it? It's a quick and easy answer. And sometimes they're big involved answers. Our daughter actually is probably more social and more sharing about her situation, her condition, but for our son, a lot of it is creative and polite ways to say, I don't care to talk about it.
Yeah, so it's giving them the option. That's a great point. Helping them say no. No is a complete sentence, right? Helping
Right.
them walk through, if they don't want to talk about it, ways they can deflect no, but, moving on to the next topic, or ways to get it down to a sentence, right? So, it could be something as simple as, I have arthritis, which means my immune system attacks my joints sometimes. Just
Exactly.
straight up. So
here's one probably for more newly diagnosed. How do we help our daughter understand that not all of her friends, or maybe many of her friends, are not going to understand and may choose to not be good friends anymore? Friends she's had or counted on for years just basically abandoning her now, or moving away as she's getting older. And how do we work through that? And I know you can speak from experience on this one.
I think, what he's referring to is I actually experienced that in high school, early in high school. I had lifelong friends through childhood. And when my arthritis got really obvious about 10th grade, 9th grade, 10th grade, man, it was like I was suddenly by myself at the lunch table. It's hard, but it kind of goes back to, okay, some of this is just normal development. And I realized, well, if it wasn't my arthritis, probably would have been something else, because, as an adult looking back, these are still the individuals that wouldn't say hi to me at the reunion, right? So it's more of a reflection on them, right, than us. A lot of kids have that response because it might make them a little uncomfortable because they don't understand. My experience, they didn't know a lot of what was going on with me. They didn't know a lot about JA compared to what they know now. So I couldn't explain a lot of what was happening to me. But it's just helping kids, come up with how to explain it. Just like, you could wear the wrong shirt one day in middle school, right? The peers are going to choose something to react to. It may not actually be anything having to do with your child personally. It's hard to get them to understand that, not to take it personally. But, if that is how they're going to react, would they want to be friends with someone, take them out of that equation. If they saw those people do that to someone else, would they want to be friends with those people still? Is that an okay behavior for them? Is that fit with their values as what a good friend should be? So you can kind of change the lens from your child saying, oh my gosh, what's wrong with me? They rejected me, to saying, well, but is that the kind of behavior you want your friend to do? Let them be proactive in choosing that social circle. But it is normal for friend groups to shift and change a lot in middle and high school.
That's a great point. And it's, I think, important really to keep in mind as parents. We've been through this with all of our kids now. It may not even be because of the diagnosis. It may be coincident with the diagnosis. And, to the kid who's suddenly trying to understand how they're different, it may feel like it, but in reality, it may have nothing to do with the diagnosis and just be the shifting of kids as they grow and develop.
Yeah, we typically in our house, when it happens, we don't pay too much attention to it. We just encourage them to refocus on, maybe another peer or something positive that happened in their day, because we don't want to put too much emphasis on it, because we know it's going to happen frequently. So our kids are going into 11th, 9th, and 7th. So watching the change as our daughter, she's now done with 8th grade and done with middle school, and her reflection on that, even how she looked at things at 6th grade versus 8th grade, she's kind of learned that lesson and recognized that. So we try not to put too much emphasis on others, because the kids don't have control over that. But hey, what can you do? Is there a new interest you want to try? Do you want to join a different club at school, meet some new people, that kind of thing, kind of keep it moving.
While we're on the topic of peer interactions, the next question here, how do we encourage our children to be more open with their peers about the diagnosis, and is it necessary?
Yeah, first they have to be comfortable with it themselves. Not every kid, is going to own it right away or be comfortable talking about it. That's okay. So it goes by your child's comfort level. If they are comfortable talking about it, great, but they don't have to. No one has a right to our personal information. I tell, my younger clients, no is a complete sentence. No, thank you. Changing the topic rapidly. Not everyone has to know what's going on. That's okay. Especially if the child isn't in a place where they're understanding or comfortable with it themselves. So, we always, say it's really at the kid's comfort level. We don't want to, make anything feel forced or feel required, right? So if they're comfortable talking about it, great. If not, that's okay too. And you can even extend that into a conversation about in what situations could this come up, or would you want to be able to discuss it with somebody? And what situations would you maybe not want to share that? And I usually hear something along the lines of, well, with my teachers, or if I'm going on a field trip, if I'm going on a sleepover, then yeah, people need to know. But if I'm meeting someone for the first time, maybe I don't want to share that yet. And that's okay.
Sure. Next one here. I'm sorry. I'm reading two lines together. My child is very opposed to seeking counseling. What are some resources? I know you've covered a few here, but what are some resources that can encourage her that it might be a good idea? Ways to access, I guess.
Yeah. So if your child's hesitant about counseling, that's okay. We never want to force it, because I can't tell you how many adults have sat on my couch, been like, man, I put this off because when I was forced to go and my parents divorced when I was 7, you get all the stories. So we want it to be something that they are approaching on their own. And there's a lot of things we can do subclinically to support them. The EAP, you can always offer like, hey, it's just once or twice. Why don't you try it out? I love getting them connected with peers. If they've got groups in your area, any other positive activity, doesn't have to be centered on the JA specifically, but just getting them connected. The number one mental health intervention is connection to other people. What we don't want to do, there's more of a don't on this one than do's. We don't want the TikTok therapist. We don't want to have them go to social media. TikTok, Snapchat, those are two of the most dangerous apps for our kids at any age. We don't want them to just watch a bunch of YouTube videos and things like that, because people are presenting, with bias on those. And we don't want kids to latch onto that and think that's truth, because most of the time it's not. But we want them to find connections with peers and then come to it on their own. So if they say, I don't want to go to counseling, I'm not doing that. You can try to explore why, like, cool, not forcing you, just curious as to why, just so I understand how I can help you better. Or, okay, you don't want to do it now, but is there a situation, where's that line, right? Well, I don't want to deal with it now, but maybe if this happens, I will. And then we always want to be comfortable as parents, if it comes up, asking the hard questions about suicide. So if a child, makes a comment like, I just want to go to bed and not wake up again. I don't want to do this anymore. I'm worthless, right? These really comments just really cut us to the core as parents. You can ask point blank, are you thinking of harming yourself? You want to be direct. You don't want to say commit suicide. You don't want to use any of the stigmatized language. You can just simply ask, are you thinking of harming yourself? Be direct. What the research shows is when we talk to kids very directly about suicide like that, it doesn't plant the seed. That's a myth. Like, it's going to make them think about it. It actually reduces suicidality by 40%. It drops it down, because now the kids know, wait a minute, you're going to keep an eye on me. You're going to talk about it, and you're a safe person to talk to. So it's okay to ask directly. If they're refusing to go, okay, when you say you don't want to go to counseling, I just get a little worried because I'm seeing this. I mean, they may not realize the impact of their well-being on others. They may not realize the impact of some of their behaviors or outbursts that it's having on the family. So giving them that kind of gentle reflection, like, okay, but when you say that, I think of this. I'm just wondering, what else can we do to help, right? Always keep that door open, but we never want to force someone to go to therapy.
Sure. Just a reminder, folks, we've got about 15 families on here right now. The question and answer window is open. So if you've got something on your mind, we've got probably about 15 minutes left for questions here. Please feel free to drop them in the question box. The next one up, since the COVID restrictions are easing now, my children wants to participate in more social activities, but I'm afraid it's too risky given her immune status. We're constantly in battle with one another about what she can safely do. Am I being too overprotective, and how can we find a middle ground?
Yeah, definitely have a conversation with your rheumatologist, with your child in the room. Let that be a group decision, because that is very specific to child to disease progression to medication. We have a lot of research early in the pandemic, a lot of research from Europe, because if you remember how it kind of progressed, Europe was kind of foreshadowing the US. So it kind of hit Europe before the US. There was a study that was done with pediatric COVID patients in Europe, and children with arthritis related diseases that were on biologics actually had a significantly lower incidence of hospitalization, need for event. It didn't hit them as hard. And that actually led to the use of certain arthritis medications to treat COVID. That was one of the kind of breakthroughs that came from that study. So some rheumatologists might tell you, yeah, with what your kid's taking, it's going to be a little more protective. You know, your level of risk can be a little bit bigger. Other rheumatologists might say, you know what, we're actively in a flare. Maybe they're only on methotrexate, suppressing their immune system. I'm not comfortable with that level of risk. So that's very much a collaborative decision. Don't let that battle stay between you and your child. Phone a friend on that one. I was actually in the position that with our two children with autoimmune, they have different autoimmune diseases, right? One's spondy, one's encephalitis. And talking to their doctors, I was kind of going to the lowest common denominator and all the precautions we have to take for our AE kid. I was actually kind of translating to the spondy child, and his rheumatologist is like, actually, mom, you can ease up, because with what he's on and he's responding well to the vaccine. I joined a vaccine clinical trial for people on arthritis meds that shows our antibody levels to the Pfizer vaccine. Like, with all this data, like, this is what we want to use to make these decisions. But everyone is also going to have a different level of comfort in terms of how much risk to take. So definitely phone a friend. Don't let that stay a battle in your house. Get the medical input on that decision and have that conversation together. Let's
Great.
see. Suspecting bullying. He refuses to open up. What would you do? Wow, Dan, does this sound familiar?
I've heard a situation similar to this lately. Yeah, I guess you saw the question pop up at the same time I did. Go ahead.
Yeah, type 3.
I've got one more on my list over here.
Yeah, it's normal for kids not to open up about the bullying because the way bully dynamics work, it's a power differential. So if you want to make fun of my hair, okay, that doesn't bother me. But if you're going to call me, you know, a cripple or attack my arthritis, well, now I'm feeling a little bit of disadvantage. So the bullies intentionally strike certain children and certain themes or targets with those children to get that power differential, you know, out of whack. Because it makes them feel better. It's more pathology on the bully than the child who's the target. So if the kid is not talking about it, you want to give them that space, but you also want to tell them, okay, we can't help what we don't know, right? How many times have we said this year? Woo! We have 2 of our 3 were getting bullied and not talking about it at all. So, you know, we can't help if we don't know. This is also the age where they try to handle these situations on their own. They feel like they're tattling, or if they're running to mommy or daddy or a teacher, right? That makes them feel kind of, you know, younger and infantilized. So they may not want to do that. We let them handle it on their own, but we say, hey, if it gets to this point, this is where I'm going to intervene. So here are the options. You can tell me about it without telling me who it is. Just let them vent and you help them problem solve within it. So this child is saying this and doing this. Okay, let's come up with some different strategies and responses without having to know, because they're afraid that you're going to go at it from a disciplinary standpoint and they're going to double down. So one option is just to talk to them, help them process their experience of it and have them decide their next step. If we're talking safety concerns, if your child's coming home and there's physical assault involved, and we know with our JA kids, some forms of JA, they're more prone to injury if they take an impact. Sometimes we do have to step in a little sooner with safety, but you tell your kids, hey, if it's a safety thing, everyone's got to be involved to handle that. But if it's just an exchange of words and your child wants to handle it on their own, try to give them that space to do it, but help them talk through the experience of it and what they want to do for next steps. And you can tell them, I just want to talk about, I don't have to know who it is. I don't have to know. You can make up a name, right? You can make it up, but I just want to hear your feelings about it to make sure you're okay.
Great. Next one. My daughter started her period about a year ago. The flares and negative emotions are worse during that time of the month. What are some ways I can help her cope and prepare for this monthly battle, since it will be lifelong?
Reach. Yeah, we have a 14-year-old daughter. I get it. First of all,
Did you write this one in here?
I didn't. I actually didn't write that one. I could have. So we don't want to think of the menstrual engagement as lifelong because we're talking about two things that are going to change. So as you know, a female person who has had arthritis since the age of 8, yes, my cycles would trigger my flares until I hit like my 20s. So we know that with just menstrual cycles, those are going to change over time and over age, right? There's a lot of variability to that. And again, we're talking hormones, which tells certain things in the body to do other things. With your immune system involvement in the JA, it's possible that that interaction at some point could disconnect. So that could, you know, some women will have a little bit of pain and achiness, some will have increased swelling, some will be all out and it's miserable and the moods go. With kids, you know, we've got, you know, young women who are new to this experience, getting them to talk about it, and it's building that insight and self-awareness. So, you know, as, you know, young women, we don't, you know, we always hate hearing people go, oh my God, are you on your period, right? Anytime we had an opinion or a mood, we don't want to go that route, but we want to just talk about it when things aren't happening, when it's neutral, and just say, hey, I've noticed this. Can I help you figure out a pattern? You know, have them jot it down in a journal, just to start tracking cycle and tracking symptoms, to get ahead of it that way, because it could be the muscle pain involved could be kind of backpedaling with your arthritis, or they could be panicking with that pain level and not able to separate the two phenomena yet. So it's just having the conversation, normalizing it, bring them a chocolate bar. The brain loves chocolate. Chocolate bribes everyone. But, you know, make it kind of a positive experience, but take it from a data, like let's help you track it and track symptoms and see if we see a pattern. Maybe these two things aren't connected. But with the moodiness, a lot of times it's temporary. Give them space, help them talk through it. It will pass.
I got one more here, and this one is about academics and performance anxiety. So my daughter puts a lot of pressure on herself to perform well at school. She's concerned about getting in honors classes in high school, and her perfectionism and anxiety is related to flares. How can I help her with this anxiety and get her to find more balance?
Yeah, so when we talk about the academics and the perfectionism and the pressure, right? This is, you know, this can be multifaceted. So some kids put that pressure and the perfectionism on as a way of expressing anxiety, right? So I will be okay if I get straight A's. Like they're tying that behavior to some type of safety. I have to do this. Like I have to be in honors or else, that kind of thing. Sometimes it is an escape from the arthritis symptoms and the pain. So, you know, if my own mother was here, she would be laughing at that question saying, oh my gosh, that's so you. Because for me, my arthritis really took a turn in high school and continued to decline, and we couldn't get a hold of it. This is before biologics were approved for my age group. So I was kind of out of control in the disease factor. And having to make a lot of changes to my life, and I was really not coping with it well. And I threw myself into school. That was my escape. So I pushed myself academically to make up for the fact that I had to quit playing sports. So, you know, when we have a kid that's focused on the getting honors, you know, getting into the honors classes, we got the perfection and anxiety. We have to kind of tease out from the child, chicken or the egg. So is the anxiety causing the flare? Or is this perfectionism a way to cope with the flare and helping them find that balance? And, you know, our kids, depending on how long they've been diagnosed, can have a tremendous tolerance for pain and flare. This might be a bargain she's willing to strike with herself. You know, I was willing to deal with maybe some shorted sleep or some aches and pains in order to study a little bit longer, or, you know, do one more thing and that kind of thing. My first career was actually music education. I was a band kid. So I pushed myself quite a bit in terms of playing my flute, past what my joints probably wanted to, but I chose that. That was that autonomy piece. I made that deal with myself. Okay, I'm going to let myself practice, but then I'm going to then ice my hands. So in terms of helping her with the anxiety and to find more balance, explore that with her. because she may not see it as an issue. She might see it as fueling the performance. That might be something she's willing to deal with. Now, as a parent, if you are seeing negativity, right? If you're seeing the emotions come out, right? And I think Dan's laughing because we have one of these at home too, like daughter, like mother, like daughter. If you're seeing that stress come out and the lashing out, and that negative self-talk, then you want to kind of take a step back with it and say, okay, when I hear this, this is what I think, and I'm concerned. But, you know, again, make that a together decision.
Great. And one last question, and this should be a pretty quick one here, and then we'll do a little bit of wrap up. How much should we push our son to do things versus let him make the decisions for himself? For example, he may not want to participate in a physical activity and is blaming his arthritis.
Wait, Dan, did you write that one?
You know, I didn't, but I feel like I could have. I'll let you take this one unless you want me to.
No, it's something we deal with all the time. You know, and it's a balance. It's really striking that balance on when to push, when to drop back. Right now, the running joke in our house, because our son has spondy as I do, so it affects muscles and joints. And I'd be like, all right, you can get out of it if you can touch your toes, because his flexibility is horrible. And so he's like, ha ha, but then he'll sit and stretch. So, you know, you can have, as part of the family culture or family rules, an expectation of movement. You can try to sneak movement in. I am constantly forgetting things upstairs and asking him to get them for me. Right? I lose my keys all the time, you know, to get him to move. So finding ways to build in the movement. When we talk about event or activity participation, some of that may be the child being afraid of embarrassing themselves, being afraid of keeping up. So it could not be the arthritis, but the impact of arthritis. So if you can make a deal, well, if you don't want to do this, what would you do? Because, you know, in our house, they have to have 30 minutes of motion a day on the list, right? We have a little checklist of activities. They got to get 30 minutes of movement a day. All right, you don't want to walk the dog. What would you be willing to do? So negotiate.
I think it's really important to include in that if we can get the kids interested and motivated. You know, for our son, right now it's summer swim season and it's also preseason for marching band. And guess what? He's on board with being active because those are things that he wants to do. And marching band has us pretty much covered through November, but then we get into the cold weather season and that favorited activity is done, and then it's more challenging for sure to find things, but running at a speed that works for him and here and there adapting a little bit, but really participating as much as possible, really is our goal. Let's wrap up. I'm going to give you a question, which is to give me your one top takeaway. We covered a lot of things tonight, but if there's just one thing we could take from all of your information and expertise to head out with, what would that be?
I think my number one takeaway is that what's going on in your house is probably more normal than you think. You know, going back to that development, that variability, and JA adds some variability. What you're going through with your child is probably more normal than you realize. It just does, because it's uncomfortable doesn't mean it's bad or wrong. And just doing as much as you can in the area of connecting with your child, connecting as a family, connecting them with peers and resources, helping them engage. They don't have to have a lot of friends and peers. One or two is really all they need. But seeking the connection as much as you can with other parents, other resources, other families, and just recognize that what you're dealing with is probably normal.
Great. Well, thank you so much. Before we call it a night, just a reminder that there's several resources and events coming up to help your child manage their arthritis, starting with the big one, which is the Arthritis Foundation's annual JA conference. Annual, but the first time we've been able to do it live in a couple of years. It is in Orlando, Florida. The script says sunny, but I'm going to say hot because I'm here right now and it's still 86 degrees out, even with the sun having gone down. But we're here in Orlando, July 14th through the 17th. I'm going to be there. Jessica's going to be there along with our kids. We're looking forward to seeing everybody who can make it. The conference offers tracks for parents, kids, young adults. The young adults is a huge one because that's its own specific group. And for the kids, they're set up by age. And it's a lot of great information, great activities for everyone, lots of topics, nutrition, pain management, mental health, and more. We'd really love to see everybody there. Please, if there's one thing that you can make, you can do it in person or you can sign up to do it virtually. But please do the best you can to make it. Also, we've got a bunch of other upcoming events, some arthritis webinars coming up, one here in June, one in August, as well as access to lots of online resources through the Live Yes program.